friends. We come back with the next edition of our masterclass on breast cancer. And today's masterclass is dedicated to ESMO updates. In this very fast changing algorithm of treatment of most of the cancers, breast cancer is seeing a paradigm shift every now and then. The number of concepts, drugs, algorithms are changing very fast. And we have many more options in both early as well as metastatic breast cancer, and the segmentation into the biology-driven or the biomarker-driven therapies is getting more and more profound. Let me share with you that we have over about 500 registrations from 24 countries. And it's very refreshing to know that we have registration from Afghanistan also for the first time. And the program is popular globally. We have actually people joining in from UK as well, Africa, Central Asia, and many other parts of the world. As I said, 24 countries. Today's program is segmented into two broad categories. We would discuss the early breast cancer and metastatic, and towards the end, have a quick 20-minute panel discussion on both the subjects. And today's program also brings in a mix of experience as well as young speakers. That's our USP. And we want more inclusive, more people to join us on these programs. And I must thank Samarth Pharmaceuticals, particularly OM, who drives all this, and also particularly keeping the agenda not their pharmaceutically driven or commercially driven. They give us a platform which is neutral and allow us to do discussions which are more academic and which are more practice changing rather than being drug driven. Friends, with that prelude, I hand over the proceedings back to Priyanshi to introduce the first speaker in session 1 on early breast cancer. Over to you, Priyanshi.
Thank you so much, sir. So our first speaker for the first session is Dr. Ashok Kumar from Sarvodaya Healthcare, Faridabad, and his topic is recent data on adjuvant RT, hypofractionation. So over to you, sir. Please stick to the time, sir. Kindly requesting. Thank you, sir.
Is my screen visible?
Yes, sir. It is visible. Yes, sir.
Yeah, thank you. First of all, grateful to Dr. Ashok Vaid, sir, for giving me this opportunity. And I would be talking about the adjuvant radiotherapy in early breast cancer. Bye-bye to standard fractionation in node-positive early breast cancer and the first results of G01 trial. Now, as we all know that early breast cancer, the radiation post-surgery chemotherapy, the radiation fractionation has been scheduled to 5 weeks, which is the standard fractionation schedule. Followed by, if it is a BCS, then we give a boost of 10 grain 5 to 7 fractions. However, this is now being replaced during in the recent past with the onset of START A, START B trials, and which was given only for a week, and then Ontario DBCG hypo, all these trials, and then ultra hypofractionation UK fast and fast forward trials. Now, in all these scenarios, we are going to radiate the nodal basin also. So with the changing scenario, do we need to stick to the 5-week regimen, or can we reduce it to the 3-week regimen so that the patient can be relieved of the treatment as soon as possible? So 2 weeks time, which we will be saving for the patient. So with this in mind, there was this trial, hypofractionation in node-positive early breast cancer, Hypo G01 trial, in which 1,265 patients were randomized to hypofractionated arm versus the normofractionated arm. So women more than 18 years of age, T1, T3, node 0 to 3, and M0 breast cancer with regional with an indication for the regional nodal radiation. So hypofractionated arm consisted of 40 gray in 15 fractions over 3 weeks with or without boost versus the standard fractionation of 50 gray in 25 fraction with or without boost. So the primary endpoint which was evaluated in this was the arm lymphedema. So let's see how did it fare. So the median age in this trial was 58 years, and in the hypofractionated arm, 614 patients, whether the normal fractionated 607 patients, so equally distributed arms. 501 patients underwent mastectomy. Axillary clearance was done in almost 82% patients, and mean of 12 lymph nodes were removed. So it was evaluated at 4.8 years with 275 lymphedemas did happen. And 27 serious side effects were seen, out of which 16 in the hypofractionated arm versus 11 in the normofractionated arm. However, the overall survival, how did it fare? Means, was it something different from the 5-week regimen, or was it somewhere better? So what we can say is the arm lymphedema rate was almost 33% in both the arms. So it was equivalent in the hypofractionated arm versus the normofractionated arm. Second point was the shoulder range of movement impairment. It was again 20% in both the arms. And toxicity rates, coming to toxicity rate, it was almost 12.6% in both the arms. It was grade 3 or higher, 12.6% of toxicity was seen. Coming to the local recurrence-free survival rates, almost equivalent, and distant-free, disease-free survival rate, almost equivalent. So this is one of those large trials which showed that tolerability of hypofractionated radiation in node-positive early breast cancer is feasible. And rather than giving a 5-week regimen, we can do away with the 3-week regimen, and which the patients are also tolerating with equivalent side effect profile, and we can deal with those side effects. There's another trial, SCAGEN-1 trial 1, which is moderately hypofractionated loco-regional adjuvant radiation therapy for early breast cancer, integrating with the SIB technique. So this trial results are also going to come out soon. So coming to the conclusion part, I will not take much time. The SCAGEN-1 trial and the HypoG01 trial for locoregional hypo versus normofractionated radiotherapy, these two independent randomized trials provide a very strong evidence that moderately hypofractionated radiotherapy is non-inferior to the hypofractionated radiotherapy in terms of risk of arm lymphedema, firstly. Secondly, the significant finding was the shift in the practice, allowing for the implementation of the hypofractionated radiotherapy in patients requiring regional radiation of the breast cancer. Now, this change not only reduces the number of radiotherapy sessions for patients, but also decreases the resource requirement for radiotherapy departments in a busy radiation oncology settings. And finally, overall, these trials have a major impact on both patient and healthcare professionals in breast cancer treatment management. Now, coming to the conclusion, I will conclude with saying that moderately hypofractionated loco-regional radiotherapy is non-inferior to normofractionated radiotherapy in terms of arm lymphedema risk in early breast cancer, and it did not lead to unfavorable safety or nor LRFS, DDFS, or overall survival concern. So I think we should change our practice of giving 5-week regimen to 3-week regimen with 40 gray in 50 fraction for locoregional radiotherapy in early breast cancer. So this was the trial which was presented in ESMO this year. And I think this is a good enough trial for changing our radiation oncology practice in early breast cancer management. Thank you.
Thank you so much, sir, for such a wonderful talk. Moving ahead with our next speaker, we have Dr. Shalabh Arora from Ujala Sinus Hospital, and he's going to talk on adjuvant endocrine update. Thank you, and over to you, sir.
I hope I'm audible and visible.
Yes, sir, you are perfectly audible and visible.
I'll just share my.
Could we request everyone to mute the Those who are not on active speakers, there is a lot of background noise.
Right. So I'll be briefly discussing on the updates that were for ESMO, and I'll be looking at the adjuvant endocrine therapy updates in early breast cancer. The subsequent speakers are going to speak on metastatic breast cancer. So these are the three papers that actually caught my eye out of the vast majority that were presented at ESMO 2024. Firstly, I'll be touching upon the Natalie trial. 4-year data has now been reported. And then we'll be looking at how young women and adherence to adjuvant, how adherence to endocrine therapy actually impacts the outcome, a retrospective analysis. And lastly, we'll be looking at ovarian function suppression in HER2 positive early breast cancer, which is again a post-hoc study. So Natalie trial, as we already know, in the adjuvant space in intermediate or high risk breast cancer, there was still a good rate of relapse, and this was a point where there was a long felt need where we could improve the outcomes by upgrading the adjuvant therapy. So Natalie trial, they randomized patients in the adjuvant setting, stage 2A, node negative with some high risk features, which were defined by grade 2 and evidence of a high KI67, or patients who had a high recurrence score on the Oncotype DX, or high risk via genomic risk profiling, or patients who had grade 3 tumors or node positive. They also included patients with stage 2B and stage 3 disease, and this was a large trial with over 5,000 patients. So patients were randomized into a non-steroidal aromatase inhibitor, which could be letrozole or anastrozole. And in addition, goserelin was added in men and premenopausal women. This endocrine therapy alone, plus or minus ribociclib. One point I want to bring to your notice over here is ribociclib over here was given in 400 milligrams per day on a 3-week on, 1-week off schedule. So this sort of takes away the toxicity that is seen with the higher doses of ribociclib that we use in other indications. And here the drug was continued for up to 3 years. So we already know the previously reported results of the Natalie trial. There was a delta of 2.7%. There was an absolute benefit at 3 years. And now with the 4-year results, it has been shown that this benefit further rises up to 4.9%, which was statistically significant. So approximate 5% improvement in the ITT population. If we dissect this data in patients with stage 2 disease, at 4 years, there was an absolute IDFS advantage of 4.3%. This was also statistically significant, as was in stage 3, which we know is a subset of high-risk breast cancer. Over here, the delta was close to 6%, which was again statistically and clinically significant. When you dissect them out by nodal status, so patients with node negative disease, they had 5% improvement in IDFS at 4 years. However, this was not statistically significant, but in node positive patients, there was a characteristic advantage with the use of adjuvant ribociclib for 3 years was demonstrated. And in summary, what one can take away from this trial is that there was a clinically relevant absolute benefit in this intermediate risk population, which we had seen previously and now is confirmed with 4 years of follow-up. And although at 4 years, we have enough convincing data that this should be offered to our patients with intermediate risk for relapse, but definitely we would want a slightly longer term follow-up and before we start discussing this with our patients. Specifically, since we know that the adjuvant trial of palbociclib was negative, although that was a slightly different population, they did not really narrow down the patients who are at high risk and should be given an adjuvant CDK4/6 inhibitor. Right. So lastly, this is the second trial that I wanted to discuss, in which patients were sorted out by the how adherent they had been to their therapy. So a clear data, they stratified patients by how often they were taking a break over an interval of 30 days or 90 days or 180 days. And patients were divided into groups of 5-year age groups. And if you can see, the earliest age that they chose was 18 to 34 and went all the way up to 69. You can see that there is if you look at the graph in 30-day breaks, the breaks were actually more the patients in the younger age group were actually much more compliant to the therapy. Sorry, they were much less compliant to therapy. And you can see a clear impact of this compliance to the outcomes, to the absolute benefit that these patients derive. Because if you look at the 18 to 34-year age group, patients who had no 180-day break, they had a much robust improvement in their IDFS. So what we can draw from this graph is that non-adherence increases at a younger age, whereas women in an elderly age group, they are much more compliant to therapy. And impact of non-adherence is also very clearly seen at this younger age. Lastly, there was this retrospective analysis of the HERA trial, which included patients with hormone receptor positive and HER2 positive early breast cancer. So outcome was sorted by the chosen endocrine therapy in premenopausal patients, whether these patients were given tamoxifen versus ovarian function suppression. We know from the soft and text trials that ovarian function suppression along with aromatase inhibitor is superior to tamoxifen. Here we are looking at the same intervention being played out in a HER2 positive population. So as you can see in these two graphs, that the disease-free survival in this HER2 positive population was there was almost a 10% difference, which was clinically and statistically significant, that was seen in patients who receive ovarian function suppression and AI versus tamoxifen. Similarly, and in terms of overall survival, which is the holy grail of oncology interventions, here also there was an 11% difference in 11% difference in terms of overall survival. So I say, like, what we have already been practicing based on the soft and text trials, that ovarian suppression plus ET plus AI is superior to tamoxifen. Now we can apply that same concept to patients who have HER2 positive early breast cancer also. However, the caveat to be noticed over here that this is not a randomized trial, and there have been better treatment strategies since the HERA trial was put into place. But nevertheless, this does suggest a benefit of AI plus OFS in high-risk patients with who are hormone receptor positive in addition to HER2 positivity. Right, I think I'll stop here and hand over to the organizers.
Thank you so much, Shalabh sir, for such an informative talk. Moving ahead, so due to some personal commitments, sir will join after some time. So till then, we can take the first talk of the next session. So we have session 2, metastatic breast cancer. And we have our first speaker for this session, Dr. Mukesh Chaudhary from Sarvodaya Healthcare, Faridabad. And he's going to speak on practice changing trial LBA 18. So over to you, sir. Mukesh sir, are you there? Hello, Mukesh sir.
Priyanshi, we can invite the next speaker till then he joins.
Mukesh sir is there in the panelist. Okay, so yeah, he's there, but he's muted. So one second, I'll just call him.
Dr. Mukesh, can you hear us? So is Colonel Ashok still there? Sir, are you there? How about Dr. Salab? Are you there?
1 second, sir. Mukesh sir is there. I'll just unmute him. He has joined.
So we can have a small discussion till then by the time he joins. Dr. Salab, how many of us will change their practice tomorrow morning based on the Natalie 4 data, 4-year data? I think he's logged out. Dr. Salabaroda, are you logged out?
Yes, Salab sir is logged out. So Mukesh sir is there. He has joined, so he'll start his talk.
Let's go ahead then. Okay.
Yes, yes. Um,
Hello.
Yes, so Vineet sir, are you ready with your talk? So we have Vineet sir with us, so we can start with his talk. Sir is from Artemis Hospital, Gurgaon, and he's going to speak on new adjuvant immuno updates. So you can start with your talk.
Yeah, so thank you very much. And thank you to Ved sir for this very kind invitation and to Samarth. So I'm now working at Fortis Shalimar Bagh for last 1.5 years. So I'm no longer at Artemis. So topic which I've been given today is new adjuvant immunotherapy approaches for early breast cancer. So very exciting topic, we have the, simple topic that is pembrolizumab keynote 522 long-term data. But we also have the new exciting approach, whether, patient were low ER, whether we should give them immunotherapy. So, we see these patients, they are not fit for hormone therapy. They are not fit for immunotherapy also. Should we actually be giving them pembrolizumab? What about, so neo-Chakra study? So neo-Chakra study looks at addition of some agents in neoadjuvant therapy, and IFSI 2.2 analysis, which is partnering immunotherapy with ADC as neoadjuvant therapy, and what kind of patient respond to it. So I think a lot of these will come into the clinic over time. So exciting to see them all. So let's start with Keynote 522, 5-year overall survival. So this was, so it has been one of the major advances, I would say, in TNBC metastatic, in TNBC neoadjuvant setting, that you can actually improve the long-term DFS by adding of pembrolizumab. And now we have the long-term data in the survival analysis as well. So if you look at the initial presentation or analysis and the paper, there's an increase in PathCR by roughly 15%. So it is 13.6%, which translates to event-free survival gain of hazard ratio of 0.63, which is a large number. Question is, does it translate to a survival benefit? Because that is ultimately what everything else is a surrogate for. So if you look at the 5-year data from Keynote 522, you can see here, this is the, if you look at the OS data, you can see that the 5-year hazard ratio is 0.66 with a 95% confidence interval 0.5 to 0.87, indicating a statistically significant improvement in overall survival, and indicates that you are actually improving the 5-year cure rate by roughly 5% by adding pembrolizumab, although 15% of patients still die. Even though you have given pembrolizumab, still it's a way forward. So if you look at the overall long-term outcome of the study, there is a survival benefit in the study, and it is there in all the subgroups, indicating that it is a valid choice for your patients. Important things to discuss is the toxicity. So mostly I think mostly we are used to the use of checkpoint blockers by now. And I don't think we see a lot of mortality due to immunotherapy toxicity nowadays. But yes, some patients will have grade 3 or 4 immune-related adverse events. Second is also the cost, whether to de-escalate, whether you can. So, for example, somebody has PATH CR. Should you give the adjuvant part of Keytruda or not? That is one important question. If somebody does not respond, what can you add in the adjuvant setting to improve their long-term outcome? And very important, can you get a biomarker? So, subgroup analysis does not indicate any clinical biomarker. Most likely, there are laboratory biomarkers which we are working on, which will indicate which patient benefit from pembrolizumab long term. So this second study is actually a retrospective analysis. So in Keynote 522, they have said that more than 1%, the threshold for ERPR is more than 1%. But if you look at a lot of studies of hormone positive, for example, last I saw in the right choice, most of the studies they take ER positivity threshold of 10%. So what to do about the patient who are 1 to 9%? So they are like orphan patients. So in India, what will happen is suppose you come to the OPD, somebody is there who has got ER positive 5%, PR negative, and HER2 negative. You are afraid to give them pembrolizumab also, but you are also not sure whether you should give them hormone therapy or treat them like, and you can't even, many times you don't even give them carboplatin. So they are kind of orphan at both sides. So this is a retrospective analysis of these patients. In EU, pembrolizumab can be used for early TNBC, including the ER low patients with 1 to 9%. And in this analysis, there was a 75% PATCR rate in ER low early TNBC, indicating that pembrolizumab addition is apparently efficient in this patient because normally you will not expect 75% PATCR. In fact, in hormonal ER positive cancer, you usually don't expect a PATCR of more than 30% or 40%. So although it is a retrospective analysis, it matches the kind of PCR you see with TNBC. So it indicates that even these ER low patients, probably you can and you should offer both carboplatin and pembrolizumab to these patients. So then this is this very, very interesting study, which is NeoChakre. So in NeoChakre, they have taken patients who are hormone receptor positive. They are luminal B patients. So they have to be grade 3 or have 2 or more aggressive features. And there were 3 arms in the study. You could give chemo with a radiation boost. So you can see it is 3 into 8 gray to the primary tumor, which is kind of an immunosensitizing dose. And they've given chemo with radiation boost alone, chemo with radiation boost with anti-PD-L1, or chemo with radiation boost with anti-PD-L1 and anti-CD73. So anti-CD73 is another, it's another kind of checkpoint receptor, and they have used a drug called oleclumab, which is a CD73 inhibitor, and they have seen how it improves the PATCR rate. And if you gave the complete chemo, the radiation, the anti-PD-L1, which is durvalumab and oleclumab, there's a sequential improvement in the PATCR rate. You can see that chemo RT alone is 17.8%, addition of immuno is 31.8%, and addition of oleclumab is 35.6%. So although the gain from IO to IO plus oleclumab is modest, the gain from chemo alone to addition of immuno is quite impressive. So getting a 31% PATCR in hormone positive luminal B type of cancer is nothing to sneer at. So I would really, it's an interesting, there was a recent study of evolumab in hormone receptor positive where also it improved the PATCR rate. So I think we are going to have the emerging role of immunotherapy in hormone positive tumor as well. Once you have got the better data, long-term data, and see improvements in EFS, I think it will come up. Only thing we need to understand is what is the right way to use these agents. So here one question is, what is the contribution of radiation? A lot of people believe now that the so-called, radio sensitization, immunosensitization by radiation effect is not that powerful, although there was initially a lot of interest in that. So in this study does not answer the question. So chemo with radiation, PATCR of 17.8, whether it actually immunosensitizes the tumor, it doesn't answer the question. But definitely there seems to be a benefit by addition of immunotherapy. And it is a, precursor to larger studies, which will help in answering that question. So again, role of RT boost, we don't know. So definitely PATCR rate is higher. And interestingly, PATCR rate is actually higher in node positive patient. So just, again, it throws up some question whether the molecular heterogeneity in node positive patient has some role to play for the better response to immunotherapy. So finally, let's come to I-SPY 2.2. So I-SPY 2.2, we know, so There is some data that topoisomerase inhibitors may enhance the T cell mediated immune response, and dato-DXd, it is similar to, sacituzumab govitecan. It is an antibody drug conjugate which binds an anti-TROP2 antibody to topoisomerase 1 inhibitor, which is the deruxtecan moiety. And in the Begonia study, they have used TNBC patient, and when you use dato-DXd with durvalumab in front line, the response rate is 80%, which you normally don't get with anything. So that is why the frontline study of dato-DXd plus immuno versus the standard chemo with Keytruda is going on right now at many centers. So I think it is an important drug for this population. It will come up. So 80% response rate in TNBC first line is very impressive. So I-SPY 2.2 is looking that if you have got high risk stage 2 to 3 breast cancer and you treat them with dato-DXd plus immuno kind of approach, whether you can, either avoid chemotherapy or get a high PATCR rate without using chemotherapy. So very interesting, these I-SPY series of studies, they are mainly intended to look at very early efficacy signals with novel drug therapeutics, and goal is to direct future lines of research. So this is a study design of I-SPY 2.2. So all these studies are complex, but all of them give very important answers, which will help in designing future phase 3 studies. So this is an adaptive phase 2 trial. And in this, patients with stage 2 to 3 HER2 negative, high risk breast cancer. So patient had to be high risk, that is luminal B subtype by 70 gene assay. And the first block is dato-DXd with durva into 4 cycles. When we do residual cancer burden testing, which is done by MRI and more or than equal to 1 core biopsy of original tumor blood with or without lymph node FNAC. So the drug is given, we give 4 cycle, then we do MRI plus core biopsy of the original tumor bed plus lymph node FNAC. If patient is in complete remission, then patient can go to surgery. If this fails, block 2 is paclitaxel PD-L1 inhibitor. Again, if this phase is complete remission, patient can go to surgery. And third block is AC with PD-1 inhibitor. So the blue and green blocks are kind of the standard which is available after keynote 522, but we have got the dato-DXd durvalumab before this blue and green areas. And goal is to see if we can optimize the therapy for these patients and whether many of the patients can actually avoid chemotherapy. So if you look at the efficacy of neoadjuvant dato-DXd with durvalumab, they have studied it in various subgroups. So DRD is DNA DDR, so DNA response deficiency, patient who are hormone positive, immune negative, and DRD negative. There is 0% PATCR, so 23 patients are non-PATCR. So only 3% moderate PATCR rate. If patient is hormone receptor negative, immune negative, and DRD negative, again, you can see PATCR rate is not that impressive. So 2 out of 23 PATCR, moderate 13% PATCR rate. So probably not enough of a signal to take it to the next phase. But patient who are immune positive, you can see a very large 65% moderate PATCR rate. So out of 47 patients, 20 patients achieve. So majority achieve PATCR with just dato-DXd with durvalumab. And patient who are immune negative but HRD positive, DRD positive, there's a 24% PATCR again, which is not impressive. Very important, hormone receptor positive patient didn't actually do that great. So in hormone receptor positive, the PATCR rate is only like 18% on modeled basis. But in hormone receptor negative, you have got a 21 out of 25 PATCR rate with a modeled PATCR rate of 44%, indicating that these patients do better. So probably the right population are immunosensitive patients who have got triple negative kind of disease. And so these are the patients where, it is holding promise, and probably this will be explored further in phase 2 or phase 3 studies. And safety wise, it is a relatively safe drug. If you look at the toxicity, you can see grade 3 toxicity is not that common. Only 4 patients out of 106 had grade 3 rash, diabetes in 1 patient, autoimmune hepatitis and AK in one patient, and grade 4 colitis in 1 patient. So not very toxic. And for stomatitis, dato-DXd needs prophylactic dexamethasone, which is used in all the studies of dato-DXd. There is one fatal AE, that is grade 5 cardiac arrest in block B. So it is in the second block. It is actually not in the dato-DXd block. So probably not attributable to dato-DXd and durvalumab. So in patients who have got high risk stage 2 to 3 breast cancer, this dato-DXd durvalumab gives 33% PATCR, and they can go straight for surgery. Modeled PATCR. So again, you have to use modeling because there are blocks, and patient you think is in CR may not actually be in CR. So modeled PAT CR rate was highest with dato-DXd with durvalumab in immune positive and HR negative kind of patients. So I think this regimen holds promise and it is being studied in the metastatic setting also and neoadjuvant setting also. The studies are ongoing across the country, and I think in 1 or 2 years we should see the result. So I will end with that, and I think very exciting time for patients when they can get access to new therapies which can dramatically alter their prognosis. And we should keep an open eye for all of these therapies, not restrict ourselves to mental block. Many times, we think कि TNBC है तो chemo नहीं दिया तो क्या दिया. I think they are antiquated thoughts in current era. And when they are based on this kind of sound science, and once they are proven by phase 3 trials, we should be open to approaching a new era for these patients. So I will end with that, and thank you again to organizing team. Thank you.
Thank you so much, Dr. Vineet. So here we end our first session. So moving ahead with our second session, metastatic breast cancer, I would like to invite the first speaker, Dr. Mukesh Chaudhary. He is the director in the field of medical oncology from Cancer Hospital, Jaipur, and he's going to speak on practice-changing trial LBA-18 Destiny Breast 12. Thank you, sir. Over to you.
Hello, I am audible?
Yes, sir, you are audible.
Good evening all, and thank you, Ashok sir and Samar Pharma. And now I am going to discuss this new trial, Destiny 12 trial, about TDXD, which has intracranial activity, which is observed in all small and retrospective patient cohort in HER2 positive metastatic breast cancer patient with stable and active brain mets. Next. This trial studied prospectively in HER2 positive metastatic breast cancer with or without brain mets. Next slide. Destiny Breast 12 study design. It is a phase 4 multicentric single arm 2 cohort study of TDXD in previously treated HER2 with or without brain mets, and it is the one of the largest prospective study of TDXD in HER2 positive brain mets patient. The inclusion criteria of this study: any adult patient with HER2 positive disease with or without brain mets. Patient receive at least 2 or less prior line of therapy, especially tucatinib naive patient, and the exclusion criteria is leptomeningeal disease. There are 2 cohorts, one is with brain mets, another without brain mets. In brain mets patient, there is a 2 subgroup, stable and active brain mets patient, and both cohorts were treated with TDXD 5.4 milligram per kg every 3 weekly. The primary endpoint in brain mets, baseline brain met patient is PFS, and additional endpoints are CNS PFS, OS, CRR, CNS objective response rate, safety and tolerability. And primary endpoint in no brain met patient is or objective response rate. Next slide. The various definition of brain mets. One is stable brain mets in which previously treated and there is no evidence of progression at baseline. In untreated, there is no requiring immediate local therapy. And previously treated and progressively previously treated but now progressing and not suitable for any appropriate local therapy. And any new lesion which is not suitable for appropriate local therapy. Next slide. Next slide. Next. Then we see analysis, data analysis at the time of around 15 months. there is a 12-month PFS is 61.6% in overall population. When we see stable brain mets patient, it is 62.9, while in active brain mets patient, it is 59.6. It is TDXT show consistently 12-month PFS in both stable as well as active brain mets patient. Next slide. When we see CNS PFS at 12 month is 58.9% in overall patients, while when we see in active brain mets patient, it is 60.1%. These data are quite significant on any other previously known drugs. Next slide. Next slide. The overall survival in brain mets patient at 12 months is 90%, which is quite significant. Next slide. The adverse event of this TDXT is most common adverse event is nausea, fatigue, and constipation. But most common grade 3 adverse event is neutropenia. But with special interest is pneumonitis. It is the most common adverse event which lead to discontinuation of this drug. When we see overall with brain mets patient is 16% patient develop ILD, while on without brain mets patient is 12.9% patient develop ILD. The usual median time of develop ILD is 168 days in both arms. With ILD, there is a chances of opportunities infection which is due to aspergillosis, either pneumocystis jirovecii. It is only seen with brain mets patient because of steroids. It is seen in 5 patients and none of the without brain mets patient. Next slide. So we have especially cautious about ILD. So we should follow strict ILD monitoring and treatment, and any patient which has significant pre-exposure and ongoing exposure of steroid should be treated with pneumocystis jirovecii prophylaxis. Next slide. Next slide. Before this trial, the treatment algorithm with stable brain mets patient as well active brain patient, trastuzumab, pertuzumab, and Texans. But with the availability of TDXD, TXD is used in second line. Next slide. Next slide. After this study, TDXD is preferred in second line therapy with active brain mets patient. And in the conclusion, TDXD exhibited substantially durable oral and intracranial clinical activity in patients with HER2 positive metastatic breast cancer with no new safety signals. Thank you.
Thank you so much, Mukesh sir, for the informative talk. Now, moving ahead, we have our next talk. So I would like to invite Dr. Arun Warrior sir. He's from Esther Medicity, Cochin, and he's going to speak on updates on new therapeutic options, ADC, immuno, and targeted therapies. Thank you, sir. Over to you.
Good evening. Am I audible and my slides are visible?
Sir, yes, you are audible. Sir, can you do on
Yeah, okay,
slide
I'll
show
put it
mode?
on the yes, slide show.
Yes, sir.
Yes,
Thank
fine.
you, sir. You are
Fine.
audible.
So good evening to all, and thanks for the opportunity, academic opportunity. So moving ahead, my talk will be about the metastatic breast cancer session. I'll be introducing you to some of the studies on newer therapeutic options. So basically, there are a few ADCs and how to utilize immunotherapy and target therapy. So these may all be new molecules, but let's see where the science is heading now. So ADTs are a new era are a new revolutionary wave in oncology, and we have a lot of antibody drug conjugates, and we have HER2, TROP2, HER3 are the main players as of now, and they are being used across a lot of solid tumors also. So as you seen here, HER2 is the most common, and the number of clinical trials is so high, around 200 are there. Majority or maybe half of them are in breast cancers, while there's something like it TROP2 and again there are a lot of breast cancer trials, and HER3 also some breast cancer trials. And all the other, there are few trials, but it is spread across multiple solid tumors and hematological malignancies. So a lot of activities going on about ADCs. So the first we will be reviewing about patritumab deruxtecan, which is a HER3 DXd in patients with hormone receptor positive, HER2 negative advanced breast cancer. So this is called as the Icarus Breast 01, and this is a phase 1 trial. This is basically from France. So the objective response rate and progression-free survival with this drug is around 53.5% is the ORR, in which there is complete responses are there in a small number. Majority of them, as we see in these ADCs, are partial responses. There are some stable diseases and a few progressive diseases also. The PFS is like this, and we'll be reviewing it later. So, like all ADCs, we are worried about ILD, particularly the TDXC. We know ILD is a major issue. So, what you see here is that compared to TDXC, there is a less ILD and less neutropenia and anemia, but it can impair the quality of life with more of fatigues and diarrhea. So, we can see that the grade 3 fatigue is to the tune of 10.1, and the diarrhea is also more than 10%. So, this can really have an impact on the quality of life. And they are like all ADCs is also grade 3 treatment emergent adverse events are to the tune of 54%. And around 10% had led to treatment discontinuation. So we should be really focusing on the adverse events in this ADC. And one thing is that there is no association between activity and HER2 expression, which I think we are all becoming familiar with this concept now. If it is even if it's HER2 null, HER2 ultra low, or HER2 low, the activity is similar. And about the ORR and PFS were all similar across these. So here I would like to introduce the concept of drug antibody ratio. The drug antibody ratio is very important in ADCs. If the drug concentration is higher, the DAR will be high, but then it can impair the pharmacokinetic properties of the drug. So that will make it not very good to use from a pharmacokinetic point of view. If the antibody ratio is high, then the potency will be low. So what the studies are telling is that the DAR of around 2 to 4 is ideal. And in the ADCs, if you compare this, the patritumab has got a DAR of around 8. The TDXT has got around again around 8, and the tropion group that we already saw that datoderuxtecan has a DAR around 4. So 2 to 4 is supposed to be the best, but there is a lot of debate which is the best assay for this are still evolving here. But I think in all the ADC, this part we should look into. The overall rates is highest in patritumab around 53.5. Destiny to TDX it is around 52.6, while the datoderuxtecan is 36.4. The PFS is again a bit higher in the TDXT group, but I think both are similar, but it is not that great in the dato. So the same payload, but and the same liquor, but the antibodies are different. So So everything is important when we look at these ADCs. So the key considerations of patritumab are that it demonstrates very promising activity in ER-positive HER2-negative tumors with a manageable safety profile. For the 10% treatment discontinuation was there, and many had fatigue and diarrhea as the main issue. So activity seems similar to TDXT, like we reviewed, but some differences are there. So considering Destiny Breast 06, there is a clear therapeutic potential in HER2 null or HER2 ultra low breast cancers, because we are aware of the Destiny Breast 06, where in this group the results were not that great. And again, because they have having the same payload and the same linker, this is unlikely to offer a clinically meaningful following the TDXT. So that was a phase 2. Now let's review about another molecule, which is a IBI 354. This is again an anti-HER2 ADC from a phase 1 study. This is from a group of tumors and breast cancer, like what happens in a phase 1 trial.
Dr.
So
Arun,
efficacy of, yeah.
Arun, if you switch off your video, your audio would become better. We are your voice in between.
Yeah. Yeah, I think it's better. So, so if you look at the efficacy of this molecule, then the ORS is definitely good. In HER2 positive across the board, it is showing a response rate of 67.8%. In HER2 low, again very good, of 41.8%. Being a phase 1, they have looked across the various mg per kg dosages also here. And again, at phase 1 trial, we are mainly looking at the treatment-related adverse events, and nausea, reduced WBC, anemia tops the list. And there is some issues of epistrikes also, which seem significant of 10.3, but they were just grade 1 to 2. So basically, grade 3 are the anemia, neutropenia, and nausea, which is here. So low frequency of ILD is there, but then the treatment duration is again less, so we really can't comment on it. So the next molecule I'd like to introduce is about ESG-401, which is an ADC targeting TROP2. And TROP2, we are aware, has been in the limelight for some time because of sacituzumab, not freely available in our part, but still we are aware of that. So it's a one ADC targeting TROP2. And the compound is SN38 there. In ESG-401, the antibody is same and the compound is same. And it's a top 1 inhibitor. And again, the DAR is mentioned there, and the DAR is around 8 here. So the dosage is also a bit different. So here it is again a phase 1A, 1B study, and again this is from China. So activity here in ER positive group, where the response is around 34%. With the PFS in phase 1A, 1B, they have reported 7.4. In a triple negative, again, our response is around 35%, with a median PFS of 3.9 months. So they have looked at the efficacy also. So it again, our response rate is around the patient with brain is around 41%, and the median PFS around 4.6 months. So some patients received a complete recurrent response, like we showed before. The previous one, the ADCs do have good penetration intracranially. So this is one more drug which can be useful in this space. So again, there were trials about drugs like ivonescimab in combination with chemotherapy in TNBC. They have tried, and they combined with the nab-paclitaxel also. This drug. Again, the response rates are promising. In ESMO 2024, they combined with the nab-paclitaxel. In PD-L1 negative tumors, some intriguing reports they have reported. The response rate to the tune of 70%. I think in ADCs we are seeing this quite high ORRs frequently. The PFS advantage is again, there are two trials. In one showed 13.5 and the other showed 9.3. But I think we have to await further results to really comment on the efficacy of these drugs. So switching gears, some few slides about capivasertib, which may be available for us, which is available for us now. So plus paclitaxel as first line treatment of metastatic triple negative breast cancer. This is the Capitello. It's a phase 3 trial. And here, Capitello, they included patients who are eligible for vaccine monotherapy, who did not have any neoadjuvant chemo within 6 months, who had a good performance status. And again, we know the HbA1c, the sugar control has to be optimized. And definitely they have to analyze the tumor sample. So there were the good numbers were there. 812 patients, 1:1 randomization to capecitably or placebo paclitaxel. There was a dual primary endpoint of in the OS in the overall population as well as in the PIK3 PTEN altered population. Secondary endpoints being PFS and safety. So what it showed was that in the overall population, the capacity paclitaxel showed a median OS of 17.7 and the placebo paclitaxel showed 18 months. That was about the overall population. But if you look at the PIK3 PTEN altered population, there is a change of not much seen here. It is around 20.4 versus 20.4. Though the hazard ratio was just 1.05. So investigated assess PFS in this numerically favored the capacity paclitaxel over placebo paclitaxel. The PFS was 5.6 versus 5.1. While if you look at the PIK3 altered population, the PFS was 7.5 versus 5.6. So we are seeing a marginally change in the PFS around the 1.5. The months change is there and the hazard ratio is 0.70. So this is what happened in the investigated assess PFS. So definitely TNPC and PIK3 pathway alteration is one area of focus now. So whether it is relevant to the therapeutic target is a question. And is there a subgroup who might benefit? We have to find out further. And should we leverage on the TNPC heterogeneity? Because TNPC, as we know, there are various subgroups. Are there like HER2 low? People are trying to tease that out. HER2 1 plus people are trying to tease that out. And to select the right molecular context for this pathway. So whether we can try combinations, so these are all toxic agents, a lot of pathways are described here. So whether we can really combine these to target escape pathways is also an area of interest. So that's all from my side. Thank you.
Thank you so much, Dr. Warrior, for such an informative talk. So moving ahead with our next speaker. We have Dr. Ankur Varshne. He is from Medanta Hospital, the Medicity, and he's going to speak on tailoring ADC and predictive biomarkers, HER low and HER ultra low others. Thank you, and over to you, sir.
Thank you. Good evening. And are my slides visible to everyone?
Yes,
Hello.
we can see your slide. Yes.
Okay, sir. So moving ahead, definitely there have been a long discussion over the presence of HER2 new low and HER2 ultra low status. And we all know the fact with the multiple trials that HER2 low status is clinically targetable. And we have an actionable drug which is currently present in India, which is Enhertu. Now the role is which patients are which group is the best, which can be maximum benefited. Because definitely there is some discrepancy between the reports to some who we say HER2 new low could not be a low. There could be increasingly eligible patients for this drug which are falsely negative, and therefore there could be some patients who may be benefited with this drug but are not tested positive. And to study this discrepancy, firstly let's study what is HER2 new low and ultra low. So starting from the right side, HER2 ISC 0 completely absent of membrane staining is HER2 new negative, while ISC 0 which has a faint incomplete membrane staining in less than 10% of the tumor cell is HER2 ultra low. ISC 1 which is faint incomplete membrane staining in greater than 10% of the tumor cell, or ISC 2 plus which is FISH negative, is considered as HER2 low. So this was the study design of the Destiny trial, and out of these, the patients, there were approximately 2,300 patients, and the samples were tested both at the local site as well as the central testing. So out of these 2,300, 1,900 sample went for the central testing, which was done with the Ventana path, assay and ISH assay. Now, whether out of these samples determined as neither HER2 new low or ultra low was 240, and samples centrally determined to have a HER2 new low status or ultra lows was 1,616. So these patients were the patients who were randomized in Destiny Breast 06, either to receive TDX or the drug of choice. But our focus is to study out of these samples, almost 1,629 patients who had local HER2 new status. And how this was done, we will study. So majority of these patients had the prime biopsy was done from the metastatic site. We see approximately 20% have the biopsy from the primary site, while approximately 66% of the patients has biopsy done from the metastatic site. And what does we found when this was tested by the central testing? There was a discrepancy in HER2 new low ISC 0 status, and approximately 94%. There was agreement in 77% patient of for HER2 new low, but for the patients who were ISC 0, there was 40% who were reclassified as HER2 new ultra low, and 24 patients were reclassified as HER2 low. So now we will discuss the results separately. From the patients who were having central lab as HER2 new 0, approximately 22% were classified by local lab as HER2 new low. So these patients definitely didn't have any advantage, and we cannot give a benefit of TDX to these patients. If we classified the patient HER2 new again from the central lab, then the patient HER2 new low were again the patient who have HER2 new 0 from the central lab. HER2 new low was detected from 6% in the local lab. HER2 new ultra low was detected as HER2 new low. There was discrepancy in 16.2%, while HER2 new low classified by both lab, there was 77% of patients. So these are the patients who are safe to be used. These are the patients in whom drug can be used. But these were the patients who were tested as low as by local lab, were tested negative and should not be offered the drug. Coming to the further classifications where we get it in, again the sample size from the HER2 new low, 35% of patients were classified as HER2 new 0 from the local lab. In ultra low category, approximately 40% of patients were classified as HER2 0, and in HER2 low category from the central lab, approximately 24.5% were classified to have HER2 new 0. So 2 out of 3 patients would have easily missed the drug if the repeat testing was not done. So the study concluded that patients who are HR receptor positive, HER2 low or HER2 ultra low definitely drive a clinically meaningful benefit from the use of the trastuzumab deruxtecan, and this benefit was identified regardless of the sample type or the location type. However, the percentage agreement for HER2 new low between the local and central lab resulted in only 78% of the samples, and almost 94% of the patients with a local HER2 new low score were centrally scored as either HER2 low or ultra low. And these patients will derive benefit from the use of NR2, while 64% of the patients who have a local HER2 new 0 score were centrally scored as HER2 new low or ultra low. So it is specifically advisable for patients who have been scored as HER2 new ISC 0 to be reassessed, and they can be assessed again for if the patients can derive a benefit from the use of this drug. So definitely after testing, we have that how can for further biomarkers we can go to study the efficacy of this drug. And we have the results from the disease trial where the resistance mechanism was from the for the NR2 was used. Prior to this study, we used to have the resistance mechanism either the changes in the population, presence of the heterogeneity in the target antigen, or inadequate internalization of this antigen ADC complex, inadequate trafficking, or ineffective payload release with the use of lysosomals, or the efflux mechanism or any mutation, targeted mutation in the efflux mechanism, or any targeted mutation such as PI3CA mutation or loss of PTEN in the cellular pathways where the resistance from the HER2 new drugs can be proceeded. Analysis from the Icarus trial shows differential distribution of HER2/neu in the cells in the tumor cells as well as in the surrounding cells. The study also focused that there is upregulation of genes involved in immunoresponses such as interferon alpha and gamma, which were enriched and affect the susceptibility to the trastuzumab deruxtecan. So now we have this DAISY trial in which the patients with metastatic breast cancer, more than 18-year-old, and who have received more than one chemotherapy regimes were included. The patients were divided into 3 cohorts. The first cohort was HER2/neu expressing, where HER2/neu IC3 plus or 2 plus with FISH positive was taken. In the cohort 2, HER2/neu low, where again HER2/neu 2 ISC, FISH negative, or HER2/neu ISC1 were taking. And in the cohort 3, HER2/neu non-expressing ISC0 was taken. And the primary objective of this study was to analyze the mechanism of resistance, where they have targeted various mutation analysis to be done. And what this study found, there is an expression of ERBB gene expression. And in case if the patient is ISC negative, HER2/neu, then ERBB gene expression doesn't affect the response of NR2. There was no significant association between the distribution of ERBB2 positive and negative cells and response to trastuzumab deruxtecan in this patient population. And again, if we study the role of immune mechanism, then the density of granzyme B and CD8 lymphocytes were studies. And the study found there is no significant change of granzyme B to CD8 lymphocytes during treatment with trastuzumab deruxtecan. And again, the response was not followed, and there was no significant association in the response to trastuzumab deruxtecan. When again the whole exome sequences on the pre-treatment fresh frozen biopsies was done, what we found out that either the presence of TP53 mutation or ARBB2 amplification or PIK3C mutation or ESR mutation doesn't have a very significant association in the response to trastuzumab deruxtecan. The drug is effective on all these mutations. So there was a significant mutation which was found out where the response to trastuzumab deruxtecan was not significant, and we noted this mutation as SBS15, which is defective DNA mismatch repair, and SBS18, which has a poor association with the response to trastuzumab deruxtecan. So the study concluded the special distribution of ARBB2 gene doesn't explain the efficacy of trastuzumab deruxtecan in patients with low HER2/neu or ISC0 patients. There is no significant change of association studied with presence of granzyme B and CD8 lymphocytes during the treatment and post-treatment. However, ERBB2 amplification presented significant association with response to trastuzumab deruxtecan, HER2 overexpression, metastatic breast cancer, and one ERBB2 mutation, which was D582N, close to trastuzumab binding site, was detected at the resistance. So we have this is a small study, and a larger cohort is needed for further validation of these small mutations. So we are having definitely novel HER2/neu agents, and definitely to go ahead with a more benefit, we need more testing methods where we can detect these tests and more productive biomarkers where response to these drugs can be predicted. Thank you.
Thank you so much, Ankur sir, for the informative talk. So moving ahead with our panel discussion. So we have Dr. M.V. Chandrakant as a moderator. He is from NH Narayana Super Speciality Hospital, Kolkata. Over to you, sir.
Right. Thank you. Thank you for that kind introduction, and thanks, Dr. Ashok Ved sir, for this opportunity. Well, we had plenty of discussion and a lot of new advances during the talk. Let us try and see what are the practice changing updates that we can discuss. Right. So we have Dr. Gautam, we have Dr. Nitish, and we have Dr. Pooja. So anyone else we have other than these three? We have only 3 panelists. Okay, just one second.
So we have Dr. Priyanka Patel ma'am and Dr. Dinky ma'am.
Right. So you just show the previous slide. Okay, go to the next slide. All right. Who else we have?
Dr. Priyanka Patel ma'am and Dr. Dinky ma'am. Vandana ma'am is not there with us.
Okay, so we have 5 panelists, no?
Yes, sir.
Right. So I will go in the same order. I will start from Dr. Gautam, Dr. Nitish, Dr. Pooja, and then I will go Dr. Priyanka and Dr. Dinky. Right. So let me keep things basic rather than complicating things. Let me have a case-based discussion. Right. So I will start with Dr. Gautam. Sir, so this is a case-based discussion. Let's see what best we can take home from the recent ESMO updates. So this is a 48-year-old lady with a right breast mass, quite an early tumor with a 4 centimeter tumor, then IDC 3 and it's a TNBC. So I'm just trying to look into the keynote 522, and this is how the chemotherapy regimen that was used. They used both weekly paclitaxel along with pembro or even weekly, and AC or EC was used. So we need to note that we use taxane platinum first, and then we used anthra in this particular trial. And this is the improvement in PAT-CR, just you can remember as 5, 10, and 15. And this is the inclusion criteria, 2 centimeter tumor or node positive. So I will start with Dr. Gautam. So, sir, what do you think, even a node negative tumor, would you still offer a 5-2 based regimen? And what about platinum in triple negative in the neoadjuvant setting?
So here presently in node negative patients, we are not offering the keynote 522 regimen. Right. So what I am doing in my patient is depending upon, because it is a clinical T2N0. So whether the decision will be based on whether the patient wants to go for MRM versus BCS.
Right.
Fine. If my patient is keen to go for MRM, insist on going for MRM, which I am not willing, then I can still offer them a surgery upfront. I will let you know why. Because I can leave off the patient from radiotherapy. Right. Because if we go for any type of neoadjuvant, whether it is a only anthra plus platinum plus taxanes versus keynote 522, we will have to incorporate radiation. So in node positive patients, we are yes offering keynote 522, but in node negative, we are still going for only anthra plus taxanes plus platinum and not adding the pembrolizumab.
Right, sir. So any reasons are like the 522 did have a good number of node negative patients also. So so that was the reason to have a N0 case. So even a node negative, they had significant number. So even for those patients, what do you think, sir? Should we offer 522?
So till the time, because the OS data was not there, right. So that was the reason not to offer these patients the only on PFS. But yes, looking into that, there is a definite OS data. We should offer the pembro also to these patients in the neoadjuvant setting.
Right. So very true. So the reason why probably you are delving into node positive was, so the TMH study, which included platinum as a neoadjuvant therapy, the inclusion was the node positive subset only, and that is a subset where there was a good EFS benefit. So now that you have a 522 where a node negative also has been 50%, and the benefit is there even in node negative subgroup. So I think, so if you look into the inclusion criteria, so either a T more 2 centimeter or node positive, any of the criteria, it was eligible for a 522 based regimen, and the benefit is there fairly in all subgroups. But I agree now that the mature OS data is there. So probably that is the reason why we will look into this, right, sir? So thank you, sir.
So there is a question in this that
Right.
if the patient has an age of 48, that is less than 50 year, should we add pembrolizumab or not? Because in the TMH trial, the
Right.
patients who were younger actually had a major benefit as compared to
Right.
the patients more than 50 years.
Right.
So at a 48, yes, you are on the edge. Whether the 522 was also bifurcated based on the age, that in the younger age they have shown a greater benefit as compared to the older age, or it has shown equal benefit, then we will have to decide that in younger we should be adding a drug or not.
Right, Sam. So very true. So if you look into the TMH trial, the dose of Pacli and carbo
Yes.
that was used was little high, like 100 per meter
And
square, and
AUC2,
AUC2.
yes.
So there were a lot of toxicities, and probably that is the reason why elderly people didn't benefit. But if you look into the dose of Pacli and carbo in the 522, it is less, like 1.5 weekly, and Pacli is 80 per meter square. So these are some adjustments that you may make. Probably that would tolerate. And there is and even in the age more than 65, there is a slide. I mean, yeah. So even that subset also benefited. Yeah. So if you are able to manage the toxicity, then maybe you should be able to. But if you're using an intensive dose, then you should be careful with more than 50 years. So that is probably the reasons why there was some differential benefit as per the age. But 522, even above 65, there were few patients, they had some equal benefit. Right, sir? Okay. So that is about the node negative age. So this is what we discussed. And now let's go to adjuvant CAPE. So let's go to these. So adjuvant CAPE was not given because the data was not, when it was designed, the data was not yet out. It was not yet practice changing. And these are some subgroups, if there is pathological complete response post neoadjuvant, that subset did not benefit. And then, so if there is a pathological complete response, that subset probably did not benefit the most. So I will go to Dr. Nitish. So Dr. Nitish, we gave, let us say 522 for a patient, and we operated, and there is a pathological complete response. So what about adjuvant pembrolizumab in a patient who has achieved a pathological complete response? Because the benefit is more in a non-PACR subset.
So I think, sir, in the present era, I would like to continue it in
Right.
the adjuvant setting also. So as we discuss about HER2, I believe I would like to treat the patient on the same lines, like we have a de-escalation protocol.
Right.
So on the same lines, I go ahead and even after achieving PAT-CR, would like to continue with the Pembro for at least 1 year complete.
Right, very true. As you very correctly said, so the same question was put to the author. The author answered that the trial was not designed to differentiate the benefit between adjuvant and neoadjuvant. So even though the benefit is more in the non-PACR subgroup, so that we cannot have a statistical answer, and the trial was not designed for it. At present, if a patient doesn't have toxicity and can afford, so we should be completing 1 year of treatment. Right. Thank you, Dr. Nitish. So this is about residual cancer burden and EFS. And these are some common questions that we encounter in 522. So Dr. Pooja, you can take up these questions. So can we combine Pembro with CAPE if there is no pathological complete response? Dr. Pooja? If Dr. Pooja is not there, then Dr. Priyanka?
Yes, so actually, we don't have any data as of now to prove
Right.
that to combine Pembro with CAPE with benefit or not. But again, we are stuck with the whatever data is available. Actually, I have a similar patient. Same, I have
Right.
given Keytruda plus Pembro, and I was just wondering whether I can give capecitabine along with
Right.
pembrolizumab or not.
Yeah, because the toxicity is not overlapping. And if you look into the hazard ratio of benefit with Createx and with pembro, probably they're cumulative. So if there are no overlapping toxicities, even though we don't have a trial, probably yes. Right. So what about the next one? If it is germline BRCA positive, what would you do? Would you give pembro olaparib
Again,
combination?
same. But again, same. But I would like to add olaparib if it is germline, patient is germline BRCA positive, looking at the amount of benefit the patient getting from olaparib if she's a BRCA mutant patient.
Right. And what about the last one? Supposing someone comes operated.
Can I offer a comment here?
Yes, sir. Please, sir.
So
yes, sir.
When this trial was designed, the results of CreateX had not been reported.
Correct, sir. Correct, sir.
So,
You're right.
That's a limitation, So the trial design did not take the absence of PathCR for those who could be eligible for capecitabine.
Right, sir. Very true. So at that time, when it was designed, the results were not yet out. That is true. Right. So, Dr. Priyanka, what about the last question? Can we give pembrolizumab in adjuvant setting? If someone has operated MRM upfront and come with node positive disease, what would you do?
I think I won't give pembro in adjuvant if they have not received the pembro.
Right. Right. So I think these are the common questions which we usually come across when we discuss 522, and probably these are the answers that, even though there is no direct evidence, as Ashok Vaid was saying, Vaid sir was saying, that we didn't have data when the trial was designed. So these are the probable answers that we can come up to, right? So now let's go to some finer dissection of the data. So this is 522 overall survival, and then what is important is ER low, So Keynote 522 used a threshold of ER/PR set at 1%. PCR 60, the rate was 65%. It was much more impressive. So PCR 75% in ER low early TNBC. So I will go to Dr. Dinky. So Dr. Dinky, so we usually come across ER1 plus, 2 plus, PR negative, HER2 negative. So very mild ER positive. So how would you treat those patients? Would you treat with a 522 or you will treat as a hormone positive disease? Because in 522, even a 1%, a low ER positive, they have considered TNBC, and the PathCR rate is very impressive. So how do you look at this low ER positive subgroup? We have Dr. Dinky. Then I will go to Dr. Gautam again. So your opinions around low ER positive.
Yes, that's clear. So if we go by the OLED score, even 1/8 and 2/8, which we call it is a low ER, are actually negative. So I will go with the chemo plus pembro in this set of patients.
Right. So I think this was one more important point what Dr. Gautam brought out. So a lower ER positive, we should not treat up to 2 plus probably should not be treated like a strong ER positive disease. We should be treating with just like a TNBC with a Keynote 522 based regimen. Right. So these are the ones, right. So thank you, Dr. Gautam, for those inputs. So now coming on to the next one is adjuvant CTK4/6. So this is a 40-year-old lady. Let's say she's not a peri, let's say she's a premenopausal lady. Right MRM done, and she is T2N1, 3 centimeters, grade 3 tumor. So ER is 6 plus, 2 plus, HER2 negative, completed adjuvant therapy. And now this patient is eligible with a grade 3 disease, or 1 to 3 nodes with a grade 3 qualifies for both Abima and Ribo. So right. So first I'll go to Dr. Nitish. Dr. Nitish, you can take up these questions. So Dr. Nitish, your view on adjuvant CTK4/6 inhibitors in a high risk HR positive patient.
As we discussed, it is a perimenopausal female. with ER positive but a grade 3 disease. So I would definitely like to go ahead in a young patient with a perimenopausal status with a grade 3 tumor with addition of CDK4/6 inhibitor in the adjuvant setting. My
Right.
choice of treatment or CDK4/6 will be ribo. Uh, I mean, sorry, see, ribo and Ebima because of Natalie, it is the I am actually biased because I've used both, but more convinced with the toxicity profile of ribo. So maybe ribo,
Right.
but definitely ribo and Ebima. Palbo, yes, because it was a play of the data which has happened, though no OS benefit, but yes, it can still be considered being the challenge of the financial toxicity if it is there.
Right. So let's go. So these, let me just share the data. So these are some IDFS differences between the two. So as we know that Natalie did have node negative patients also. This is the hazard ratios of 4-year IDFS, and the 5-year data of Monarchy is there with a staggering 7.6% IDFS difference. So these are the curves. You can see an incremental improvement in the IDFS that's being there as you follow up over a period of time. This is what is known as the carryover effect, and the distant relapse-free survival is also significant. So therefore, adding a CDK4/6 would be a great choice, and we need to select out which are those high-risk patients. And as you see, almost all the subgroups have benefited, even though the benefit is more in the node positive subgroup, and in the node negative subgroup, it's crossing unity. Probably the number of patients were less. The magnitude of benefit is lesser. And so few things that you need to remember is, if I have to use tamoxifen only, then we cannot combine it with ribociclib. On that occasion, we need to use abemaciclib. So tam plus ribo cannot be used, whereas aromatase inhibitor with ribo can be used, whereas tam can be used with abemaciclib. There was some issue of QT interval prolongation. So these are some subgroups, based on the intrinsic subtype or oncotype DX, whether it is low risk, high risk, all of them benefited. Or even in the BRCA mutant subgroup, Monarchy did show a benefit. So Ki67 is more prognostic than predictive, and these are some guidelines that have endorsed a high strength of recommendation for adjuvant CDK4/6 inhibitor, and these are some hints that if a patient is qualifying for both, then based on the long-term follow-up and the magnitude of difference data, Abema is sort of preferred. Again, both of them are approved in this settings. So the take-home should be that we need to identify high-risk HR positive patients who would benefit with adjuvant CDK4 inhibitor. We should be careful if you take a N0, because the hazards are crossing unity. The benefit is incremental, and the curves are separating over a period of time. So both the drugs are reasonable, and we can use either of them based on the comfort and the long-term data that we have. So
Dr.
thanks.
Chandra, sorry
Yes,
to
sir.
interrupt you here.
Sure,
There's
sir.
a question in the chat box that should we start OFS and tamoxifen first, then after some time we should start AI, or from the very beginning OFS plus AI, since we were discussing this topic a little while back.
Right, sir. So yes, so I think ovarian function suppression has shown a survival benefit based on the soft and text trials. Therefore, definitely in those patients who received chemotherapy, we must use ovarian function suppression, because just a menopause is not an indicator of menopausal status. So once we start ovarian function suppression, so for the ticking over of complete ovarian suppression, there is a lag of 1 or 2 weeks, and some suggest 3 weeks. So some suggest using TAM for a couple of weeks and then going on to letrozole. But if you look into the clinical trials, they have used OFS plus letrozole from day one itself. So in practice, I use it if I've got an ovarian function suppression done. So I would obviously use aromatase inhibitor from day one itself. So, but I agree, for the nadir to achieve, it will take time, but over a period of time, it is usually achieved. So any thoughts by you, sir, on this?
Thank you so much for that clarification.
Thank you, sir. Thank you. Right. So now let's go further quickly. We have a few more papers. So this is, this is some interesting data. So this is a 45-year-old lady, MRM done, N plus disease. This is triple positive. 4EC, paclitaxel radiation done on trastuzumab maintenance. So now in a triple positive disease, which endocrine maintenance has to be given? So this is the question. This came, you could have used TAM alone, TAM plus ovarian function suppression, or aromatase inhibitors plus ovarian. So Dr. Pooja, what you would choose in practice? So let's say a triple positive with trastuzumab maintenance, which endocrine partner would you use as a maintenance? Dr. Pooja not there, then I will. What about Dr. Priya? Dr. Priyanka?
So again, 45, premenopausal, strong hormone positive. So I would like to use AI plus OFS plus trastuzumab maintenance.
Right. That is what we use, and there is a data right now. This is the exploratory analysis of the HERA trial. So previous to this, there was some data that tamoxifen is more effective in combination with trastuzumab, but this is the external analysis saying that using ovarian function suppression even in HER2 positive patient is beneficial, and more information is if I use a ovarian function suppression with an aromatase inhibitor is better. So if you have a premenopausal and if you want to use endocrine partner, here we have the data of an exploratory analysis of the HERA trial where the overall survival of OFS plus AI is better than OFS plus TAM. So these are the conclusions of that particular trial. The addition of OFS to adjuvant endocrine therapy improved survival and optimized ovarian function suppression. And this highlights that aromatase inhibitor might be a potent endocrine partner if you are using along with trastuzumab. Right. So these are some new drugs like partitumab deruxtecan with a very impressive response rate that we saw. So now, I'll go to Dr. Gautam again. So Dr. Gautam, we just saw a presentation at the last saying that there is a discrepancy of HER2 negative versus low HER2. So in my practice, when a HR positive patient or a TNBC patient is progressing, right, when I want to really know whether it is a HER2 low or a HER2 negative, I go back and check the IHC reports, whether it is 1 plus 2 plus or whether it is 0. So even if the HER2 is 0 by IHC, do you review your slides again? Because in those, like, let us say a couple of years back, HER2 low was nothing. Like HER2 1 plus or 0 didn't carry that importance. But today, it carries an importance and there is a significant discrepancy of 20 to 30%. So Dr. Gautam, what are your thoughts on a HER2 0 or a HER2 1 plus? Would you review your slides? Because you have to give TDXT for those patients.
Yes, dear. So because so still now means pathologists are not inclined to report is at 0, null, 0, low, ultra low, or 1 plus and 2 plus. So if I am looking to go for something which has an impact based on the HER2 levels, I will have to review the slides or have to rebiopsy and tell my pathologist that that is the reason I want to look for it. So yes, surely we will have to look for the slides or rebiopsy.
Right. So again, very important message, as you said, because a couple of years back, HER2 0 or 1+ didn't make a difference, but today it makes a difference. So therefore, if you have some patient where patient is eligible for a TDXD, then in those patients, even though a patient is HER2 0, it is meaningful to have a slight review, because there is 30% discrepancy if you are missing it out. So therefore, it is important to get it reviewed again and make sure that this patient is eligible for TDXD based regimen. So these are some new drugs which are really effective, and hopefully once these are available, this would be great. So this is PIK3 mutation, or let's say PIK AK3 mTOR pathway mutation. So if you a lot of times we get PIK3 mutation being present as I do an NGS, I get a PIK3. So is it valuable? This is a TNBC subset. Is it valuable to use Kepivasertib? It is a potent PIK3 AKT mTOR pathway inhibitor. So is it valuable to add a PIK3 inhibitor? I have seen like TNBCs with a PIK3. We have used alpelisib in some patients desperately, and it has not responded. Here we have an evidence where there is no OS difference if I use a PIK3 AKT mTOR inhibitor. So, Dr. Nitish, any thoughts on PIK3 inhibition in a TNBC? Even with paclitaxel, if you combine, it has not shown much. It's a negative trial, but it is important. Just targeting a PIK3 is not that productive in a TNBC.
I think so. It just tells us as a prognostic marker that it is a poor prognostic indicator.
Right.
So using alpelisib or the capecitabine, I feel it is not going to help us much. Even we have seen that even in HER2 positive, hormone positive patients, when we get a PIK3 mutation, either the drug is difficult to tolerate, or if there is a progression, that is going to be very quick. So in TNBC, I don't feel it has a great utility.
Right. So thank you for your input. So let's have some final take-home message before we complete. So we had some I-SPY trial. I-SPY trial was presented by Dr. Vineet. So he delved into the details of it. So can we use a chemo-free regimen in a triple-negative breast cancer, Dato-DXd being the antibody drug conjugate? It showed impressive pathological complete response, and this is mainly in the immune-enriched population. Still, it is not a practice changing. Once it comes, then we should look into it. And then CNS active drugs. So HER2 agents. So CNS active HER2 agents. So Dr. Priyanka, you want to comment on CNS active anti-HER2 agents? So which are the ones? If you want to classify from the best to the least, so what would be your order of classification for CNS active HER2 inhibitors? Dr. Priyanka?
Yes. So
Right.
of course, anti-HER2 agent active in CNS in terms of activity. So first I would label TDXD, then TDM1, and tucatinib and
Right.
lapatinib.
Right.
These are the agents which active on CNS, anti-HER2.
Correct.
So whenever
Correct.
I have chances in intracranial disease, a patient with CNS mets, symptomatic radiated, so I would like to use TDXD if possible first.
Right.
Looking at the response and data we have.
Right. So we just saw the largest trial data having significant PFS,
Yes.
1 year PFS of 65 to 70% with TDXD. So as you said, the most active CNS agent, if you have brain mets, if it is not symptomatic or requiring local treatment, then TDXD has a impressive response rate, number one. And then you have tucatinib having excellent penetrance, and then you have a Chinese drug, pyrotinib, again doing excellent in the brain, and then TDM1, as you said, and you have neratinib, lapatinib, these are also doing good. And there are some new data of high dose trastuzumab. They have used weekly 440, and that has also given some 6 months PFS in the brain. So till now, you have TDXT being really active in the CNS, and we saw the largest data just now. So I think we had a comprehensive discussion on all the newer developments. We just focused on the practice-changing trials. So just to put things in perspective, number one, Keynote 522, there is overall survival benefit, which we cannot ignore, and the benefit is there even in the node negative subset. Number one. Number two, even a ER low, that subset also benefited. So a ER low should not be treated with a HR positive way. We should treat it like a TNBC way. That is one. Number two, adjuvant CDK4/6 inhibitors are important. Pick up that high risk and give the best possible CDK4/6 inhibitors, because there is an impressive IDFS benefit. And be sure what you're combining with tamoxifen, whether it is abemaciclib, because with ribo there is an issue with QT prolongation. And then thirdly, we looked into the HER2 zero and HER2 low discrepancy, 30% discrepancy if you have not spoken to the pathologist. Therefore, it becomes meaningful in getting a HER2 zero reviewed, because there is a 30% chance that it may become HER2 positive and they can become eligible for anti-HER2 therapy. And then we looked into the endocrine partner in the adjuvant setting with trastuzumab. So aromatase inhibitor plus ovarian function suppression has shown a survival benefit if you are using combination with trastuzumab, even in a HER2 positive, in a triple positive disease. And then we looked into the AKT PIK3 AKT mTOR pathway, the Capitulo 290 trial, which did show that just randomly combining capivasertib with chemo did not yield overall survival. Therefore, we should be careful before we use these drugs in practice. And then finally, we also discussed on the CNS active anti-HER2 agents, TDXT, having impressive data and a very large data again in using in CNS active disease. So with this, I would thank all of the panelists for their active inputs, and I would again thank Ashok Vaid sir for the opportunity. Thank you, sir.
Thank you, Dr. Chandrakant, for that wonderful summary. And we have had the last 1.5 hours, great discussions, great presentations, and really an academic feast. Very good insights into the trials which are practice changing. And the point is underlined that the pace of change has become so quick that we were not talking of, or we were not interested in the HER 1 and 0. Now suddenly both of them have become actionable and there is a drug available. I thank all the participants, all the attendees. At one point in time, we had 329 live attendees, which speaks volumes about the faculty, the choice of the presentations, and the robustness of the presentations. I thank Samarth Pharma, as I said in the beginning, and Om. Nothing to do with the products of Samarth Pharma here, but great participation and keeping the whole program very neutral and very academic. And many thanks to Mice Ideas, Rajesh Sharma and Priyanshi for the support they always give, and all the faculty members, presenters, all the panelists for the wonderful job they have done. And last but not the least, the attendees once again. And we have many more programs lined up this month and in the coming year. Please come back these programs. And one of the programs is hepatocellular carcinoma on the 18th, and then post-ASH. We are discussing the practice-changing abstracts again. Thank you once again. Good night. Take care and see you soon back again. Thank you so much.